arteries, the umbilical artery. So the umbilical artery, I have a PRF of 18. I need to reduce the umbilical artery PRF, and I need to increase the gain. When I'm looking at it, I can see that the bladder is present, but I'm looking at it, I'm only seeing one umbilical artery. Now, my question when I only see one umbilical artery is maybe because I do not have the right angle in which I'm seeing the artery. So the next step that I go to is I use slow flow. So I turn on slow flow, I increase my acoustic output, and then I increase my gain. And then I look to see whether I can see the other umbilical artery. So now the other one comes into view. But you can see that it was very misleading that with colour you think there's only two arteries, but when you turn on to slow flow you can see the second. The second thing that you also notice when you increase this is you see that this artery is bigger than this artery. And that's quite common. And when you see that in the first trimester, that there's a discordance in the size of the artery, then come off colour and then just find a loop of free chord, and then just look at a loop of free chord, and sometimes this can also help, sometimes, not always. And then you just look at a free loop of chord and just ask yourself whether you can see the correct number of vessels on a free loop. And so that's just a quick trick. Coming back to the baby's heart, I can see this, looking at the baby's heart, that the left and right cardiac ventricle are normal in size. I can see that the cardiac outflow tracts look normal. I can see that there's a bilateral pleural effusion, and I also think that there may be a pericardial effusion because I'm looking at the apex of the heart. I think there's actually fluid surrounding the heart as well, that the heart seems to be free. But that doesn't surprise me if that's present. But this is a normal pulmonary artery, normal aorta, and normal SVC. So my next step is I want to look with slow flow technologies. So I split my screen into a 2D and 2DC. And for this, to look at the ventricles, I want to see the fill of the ventricles. So for this, I'm going to start by pulling back on the acoustic output and also pulling back on the color gain, and then see what the fill of the ventricles looks like. And then from there, come out to look at the subclavian. So I'm going to come up to look into the fetal arms. I'm going to increase my flow, and I see my subclavian artery coming into view just here. It's not average, that's normal, because it's halfway from the chest into the spine. So there's no average subclavian. So I have not found a cardiac cause, so then I wonder, well, why is this baby hydropic? So the next thing I want to know is there something sleeping? So I want to know to the long bone for sure. The femur length is okay. And the femur length is the first bone that you look at. So I want to look at the baby's face. And I want to say, is there any facial dysmorphism? So I come around to the face, and first of all, the thing that I see is there's a gap in the mandible. And a gap in the mandible is normal. That tells me that there's no micronathia. And then I come up to the alveolar ridge looking for any evidence of a cleft. So I come up to the alveolar ridge, I can see that the hard palate is intact and the lip is continuous all the way across. When I look at the baby's eyes, I come across and I see there's no evidence of hypotelorism. So I see the orbit on each side, and I can see present in each orbit, I can see there's a lens within the baby's eye. There's no signs of hypotelorism on either side. So the orbits look normal, the face looks normal, the four sections of the heart looks normal, the mandible looks normal, the four-chamber view of heart looks normal. I have not done a detailed examination like before. I've done a screening examination. The next I'm moving down to the skeleton. When I look to the skeleton, I'm going to increase my dynamic range, and I'm looking at the scapula, because I want to know, does this baby have a skeletal dysplasia? So as I come around, I look at the scapula on this side, because sometimes the scapula is absent. That may be the first clue to me that I'm looking at a baby with a skeletal dysplasia with hydrops cutaneous. I always think cardiac first, and then I think of skeletal next. When I come across on this baby, I can't see any evidence of a skeletal dysplasia. And this is the scapula on the opposite side. So both scapula are present. When I come across to looking at the ribs, I always increase my dynamic range. I want to look at the kidneys, see if there's any renal tract abnormality. As I come across to both kidneys, I can see the kidneys are quite hyperechoic. Just going to pull down my dynamic range, so it's going in the reverse direction, slightly increase my gain. And then I'm just going to do like I did before. I'm going to go straight to slow flow in this baby. And if I'm having difficulty seeing, I like to split my screens, because what I'm doing here is I'm actually looking on the left-hand side of the screen. I'm not looking at the right. And I'm looking at the left until I can actually see that I've got both kidneys in view. And then once I see both kidneys in view, I then turn my eyes to the right screen to see that I've got kidneys. And that's the advantage of doing a split screen, is you image looking at the left screen until you've got both kidneys in view, and then you switch to the right. And that's just the easy thing to do. And then I just go down to the iliac crest. So if I look at the iliac crest, I'm finished. Iliac crest, an iliac crest here, and an iliac crest here. Okay. And then I come down to the femur. I'm looking at the femur, and I'm looking at the femur, and then I come down to the tibia, and the fibula, and the tibia, and the fibula on both sides. It's helpful to city loop record these because it's very time efficient not to take a picture of every single bone in a diagnostic examination. So frequently when I'm examining the skeleton, is I'll take city loops. In terms of working out whether it's achondroplasia later pregnancy, the femur to foot ratio is a useful thing to do. So if a femur foot ratio is less than 0.6, it works towards achondroplasia rather than growth restriction, short bones. But unfortunately there's no chart for the first trimester. But still, I look at the feet. It's much harder counting the digits of the feet when compared to the digits of the hand. And you simply look to see whether the foot is wider than it should be, and that foot is not right. And so that looks normal. I then look at the placenta, just wondering, is this any suggestion this could be triploidy? And so diametric triploidy, you get a big thick placenta. So if you look at that, that's quite a juicy placenta. The lipo volume is okay, but in proportion to the placenta size, it's low. So you're wondering, why would the baby be structurally normal in the setting of you have to start thinking of a genetic basis to it. And I think that's really about it. But in terms of the intrahepatic venous anatomy, I can just touch very quickly on that. Any baby who's hydropic, we think of torch infection, we think of parvovirus infection. So you need to look and see, could this be parvovirus? You would need to do a blood sample on the mother and do a parvovirus IgG and IgM. A parvovirus can present like this in the first trimester of pregnancy. And I would also do a torch screen just to see if there's any evidence of cytomegalovirus infection. In terms of coming down to the level of the intrahepatic portion of the umbilical vein, I just see that this is curving away from the heart. This is present in 0.5% of the population. And it's the J hook, if you follow the J hook of the intrahepatic vein coming in and sweeping away from the stomach, this is a normal configuration. In terms of doing the middle cerebral artery Doppler, unfortunately there's no chart really for looking at the middle cerebral artery Doppler, but the technique as to how to do middle cerebral artery Doppler is you come down to the base of the brain, and then you turn on looking for your circular willis, and then once you've got your circular willis, you magnify your image, just again, and now you demonstrate your full circular willis. But as I say, for looking at the second trimester of pregnancy, there's no chart for looking for evidence of fetal anemia. And when you are doing a Doppler assessment in the second trimester of pregnancy, make sure you sample gauge near the internal carotid artery, because the further you sample going away from this, the lower the velocities will be. And I know somebody spoke earlier on today about looking at peak systolic velocities. Just make sure that when you're measuring peak systolic velocities with parvovirus or any other cause of fetal anemia, that you need to sample as close as possible to the internal carotid, ideally in the proximal 1/3. If you measure too far away, you will get a falsely low reading on your MCA.